Okay, now let us start with chapter 68 of Apurba Sastry Essentials of Microbiology, which is about miscellaneous viral infections of the respiratory tract. In this chapter, we will be previewing infectious mononucleosis, adenovirus infection, and rhinovirus infection like common cold. This chapter will cover various viral infections of respiratory tracts, infectious mononucleosis, adenovirus infection, and rhinovirus infection, common cold. Infectious mononucleosis. Epstein-Barr virus causes infectious mononucleosis and is also associated with several human tumors including nasopharyngeal carcinoma, Burkitt's lymphoma, Hodgkin's disease, and B-cell lymphoma. Morphology of EBV. EBV is a member of gamma subfamily of herpes viridae family. They possess dsDNA, are enveloped within an icosahedral symmetry. EBV expresses three classes of antigens. Latent phase antigen, they are synthesized during the period of latency. Example, EBV nuclear antigen EBNA. Latent membrane protein. Early antigen, they are non-structural protein which help in viral replication. And late antigens, these are the structural protein that form the viral capsid and envelope. Pathogenesis. EBV is transmitted by oropharyngeal contact through infected salivary secretions. EBV receptors. EBV binds to specific receptors present on B cell CD21 or CR2, which are also receptors for C3b component of the complement. Such receptors are also present on pharyngeal epithelial cells. Primary infection occurs in the oropharynx. EBV replicates in the epithelial cells or surface B lymphocytes of the pharynx and salivary glands. Infected B cells become immortalized by the virus and synthesize large number of variety of immunoglobulins, polyclonal. Many of those are autoantibodies, example heterophile antibody to sheep RBC antigen. In response to this, the bystander CD8 T lymphocyte are stimulated and appear atypical, a feature which is characteristically seen in infectious mononucleosis. Oncogenicity. Persistent EBV infection can induce malignant transformation of infected B cells and epithelial cells by expressing latent EBV antigens such as LMP and EBNA. Clinical manifestation. Infectious mononucleosis. It is also called as the kissing disease because transmitted through salivary contact or glandular disease. It usually affects young adults, not children. It is characterized by headache, fever, malaise, pharyngitis, cervical lymphadenopathy, hepatosplenomegaly, rashes following ampicillin therapy, atypical lymphocytosis, CD8 T cells, and autoantibodies reactive to sheep RBC antigen detected by Paul Bunel test. Comparison of infectious mononucleosis and mononucleosis-like syndrome. Agent of infectious mononucleosis is Epstein-Barr virus EBV, while mononucleosis-like syndrome is caused by CMV 20 to 50%, HHV6, Toxoplasma, Ehrlichia, and HIV. Atypical lymphocytosis is seen in both. Clinical symptoms of Epstein-Barr virus are fever, myalgia, hepatosplenomegaly, exudative pharyngitis, cervical lymphadenopathy, rashes following ampicillin therapy. In EBV-like syndrome or the infectious mononucleosis-like syndrome, it presents except all these except that exudative pharyngitis, cervical lymphadenopathy are absent. Now, in EBV infection, heterophile antibodies are elevated detected by Paul Bunel test, while they are negative in infectious mononucleosis-like syndrome. Specific antibodies in infectious mononucleosis are specific to EBV antigens are elevated, and in mononucleosis-like syndrome, antibodies to CMV or other antigens may be elevated. Now, the EBV associated malignancies. EBV is associated with several malignancies such as Burkitt's lymphoma, nasopharyngeal carcinoma, Hodgkin's lymphoma, and non-Hodgkin's lymphoma. Other conditions associated with EBV, lymphoproliferative disorder is seen among immunodeficient patients. Example, Duncan syndrome, which is an X-linked recessive disease affecting young boys. Oral hairy leukoplakia, wart-like growth of epithelial cells of tongue developed in some HIV-infected patients and transplant recipients. Chronic fatigue syndrome, all these are the conditions which are associated with EBV. Now, epidemiology, EBV is worldwide in distribution. Age, EBV infections are most common in early childhood with a second peak during the late adolescence. However, infectious mononucleosis is common among young adults of developed countries. Prevalence, EBV is common in all parts of the world with more than 90% of the adults being seropositive and develop antibodies to EBV. Transmission, in Intimate and prolonged oral contact is required for effective transmission. EBV is spread by direct contact with oral secretions, example salivary contact during kissing. Other models are blood transfusion and following bone marrow transplantation. Source: asymptomatic seropositive individuals shed the virus in oropharyngeal secretions. Shedding is more in immunocompromised patients. Lab diagnosis of Epstein-Barr virus: antibody detection, non-specific heterophile antibody detection, Paul Bunel test, differential absorption test, monospot test. EBV specific antibody detection: ELISA and indirect immunofluorescence assay detect antibody to viral capsid antigen, EBNA and early antigen. Molecular methods: detect EBV DNA by PCR, quantifies EBV DNA by real-time PCR, detecting genes BAM, H1W, EBNA1 and LMP. Detects EBER RNA by RT-PCR and EBV antigen by direct immunofluorescence assay. Now the lab diagnosis. Antibody detection: heterophile agglutination test, Paul Bunel test, is a tube agglutination test that uses sheep RBC to detect heterophile antibodies in patient serum. Serial dilutions of inactivated 56 degrees Celsius for 30 minutes. Patient serum are mixed with equal volumes of 1% sheep RBCs and then the tubes are incubated at 37 degrees Celsius for hours. Result: agglutination titer of more than 256 is considered as significant. False positive heterophile antibodies are non-specific, may also be present following serum therapy or even in some normal individuals. Therefore, the result needs to be confirmed. Differential absorption test and monospot test are available to confirm the result of Paul Bunel test. EBV specific antibody detection: various formats such as ELISA and indirect immunofluorescence techniques are available to detect specific EBV antibodies. These tests have become more popular and are almost replacing the traditional heterophile antibody test. Antibody to viral capsid antigen VCA. IgM type indicates current infection. IgG type is a marker of past infection and indicates immunity. Antibodies to early antigen EA also indicate current viral infection. They are elevated in patients with Burkitt's lymphoma or nasopharyngeal carcinoma. Antibodies to EBNA, Epstein-Barr nuclear antigen, reveal past infection but fourfold rise of titer may suggest current infection. Other tests: detection of EBV DNA by PCR, EBER RNA, EBV encoded small RNAs by reverse transcriptase PCR, or EBV antigen by direct immunofluorescence technique have been useful for detecting the virus in various malignancies and in infectious mononucleosis. Real-time PCR quantifying EBV DNA load in blood is extremely useful to monitor the treatment response in patients with lymphoproliferative disease. The various genes targeted are BAM, H1W, EBNA1 and LMP. Virus isolation: it is laborious, time-consuming 6 to 8 weeks and highly sophisticated, hence not routinely performed. Treatment: Epstein-Barr virus infection treatment. Supportive measures such as analgesics are used in the treatment of infectious mononucleosis. Acyclovir is useful in the treatment of oral hairy leukoplakia. Though relapse is common, it reduces EBV shedding from the oropharynx but has no effect on immortalized B cells. Hence, it is not effective for infectious mononucleosis and other malignancies. Antibody to CD20 rituximab has been effective in some cases. Prevention: the isolation of patients with infectious mononucleosis is not needed as temporary contact does not transmit the infection. No vaccine is currently available. A vaccine trial using EBV glycoprotein was found to be ineffective. Adenovirus infection. Adenoviruses are non-enveloped DNA virus. It has icosahedral symmetry with fiber proteins projecting from each vertex, which gives a unique space vehicle shaped appearance. Clinical manifestation: adenovirus infect and replicate in the epithelial cells of the respiratory tract, eye, gastrointestinal tract, urinary bladder, and liver. Though one-third of serotypes can cause human diseases, types 1 to 7 are most common worldwide. Respiratory diseases are the most common manifestation of adenoviruses. Upper respiratory tract infection in children, mainly caused by serotypes 1, 2, and 5. Among adolescents and serotypes 3, 4, and 7 cause mild respiratory infections. Pneumonia. Adenoviruses, particularly types 3, 7, and 21, are responsible for about 10 to 20% of pneumonia in childhood. Serotype 14 is associated with severe pneumonia in healthy young adults. Acute respiratory disease syndrome outbreaks among military recruits are commonly associated with type 4, 7, and occasionally type 3. Now, the ocular infection, pharyngoconjunctival fever, it tends to occur in outbreaks at children's summer camps, also called as swimming pool conjunctivitis, and is associated with types 3 and 7. Epidemic keratoconjunctivitis or shipyard eye, it occurs mainly in adults and highly contagious, caused by types 8, 19, and 37. In this figure, we can see the schematic diagram of adenovirus. We see the hexon, penton base, and double-stranded DNA. The head of the fiber is circular, which gives it a space wheel like appearance, space beaker like appearance. Now, infantile gastroenteritis, serotype 40 and 41 may account for 5 to 15% of the cases of viral gastroenteritis in young children. Acute hemorrhagic cystitis in children, especially in boys, caused by serotypes 11 and 21. Immunocompromised patients are at higher risk of developing serious pneumonia. Transplant recipients may develop pneumonia, hepatitis, nephritis, colitis, encephalitis, and hemorrhagic cystitis. Types 34 and 35 are isolated commonly from transplant recipients. Lab diagnosis. Depending on the manifestation, various specimens such as throat swab, conjunctival swab, stool or urine may be collected. Virus isolation, primary human embryonic kidney cell line, and A549 cell line are the most susceptible cell lines. Viral growth can be detected by characteristic cytopathic effect, rounding and grape-like clustering of solar cells, and antigen detection by immunofluorescence direct test. Serotyping, type-specific antigen viral capsid proteins can be identified by hemagglutination test targeting HA antigens and neutralization test targeting capsid proteins. Direct immunofluorescence test can be employed to detect adenoviral antigens from clinical samples such as throat or conjunctival secretions by using fluorescent tagged anti-hexon antibody. Fastidious enteric serotypes such as type 40 and 41 from stool are seen. They can be detected by electron microscopy or by antigen detection by ELISA. Molecular methods, PCR has been available targeting group-specific conserved hexon or fiber genes. Multiplex PCR followed by sequencing is done for detection of adenovirus types. PCR is rapid and more sensitive than conventional culture. Real-time PCR is used to monitor viral load, which is useful for immunocompromised and transplant recipients. The biofile film array respiratory and gastrointestinal panels are available for simultaneous detection of many microbial pathogens including adenoviruses. Serum antibody detection can be done by ELISA. Now, the treatment and control. Symptomatic treatment is given only in the severe cases of pneumonia. Cidofovir is recommended. General preventive measures are effective hand washing, sodium hypochlorite to disinfect the environmental surfaces, chlorination of swimming pools and wastewater, and strict asepsis during eye examinations. Now, adenovirus used for gene therapy replication. Defective adenovirus can also be used as live virus vectors for the delivery of vaccine antigens and for gene therapy. Example trials on adenovirus vector and tuberculosis using 85A antigen, HIV and COVID-19 vaccines. Rhinovirus infection, common cold. Rhinovirus are the most common cause of common cold. They belong to Picornaviridae family, which also includes enteroviruses. They use host cell intracellular adhesion molecule 1, ICAM1 as the receptor. More than 100 antigenic types have been identified. They are similar to enteroviruses in structure and properties except that acid labile, unstable below pH 6 and transmitted by respiratory route. Clinical features. The incubation period is about 2 to 4 days. Common cold syndrome, rhinoviral symptoms are similar to that of any other virus causing common cold syndrome such as coronavirus, adenovirus, enterovirus, parainfluenza virus and influenza virus. The primary disease in adults present as rhinosinusitis. Usual clinical symptoms include sneezing, nasal obstruction, nasal discharge and sore throat but no fever. Secondary bacterial infection may produce otitis media, sinusitis, bronchitis and pneumonitis, especially in children. Relapse. The average adult gets 1 to 2 attacks per year. Lab diagnosis. Rhinovirus can be grown in human diploid cell lines such as WI38, MRC5 cell lines Most of the strains grow better at 33 degrees Celsius nasopharynx temperature, but not at 37 degrees Celsius. Treatment is supportive, which is symptomatic treatment. Now, short notes on infectious mononucleosis adeno and rhinovirus infections can be asked in exam. Now, MCQs. Which of the following virus agent of infectious mononucleosis? It is the Epstein-Barr virus. Which of the following tumor is not caused by Epstein-Barr virus? It causes post-transplant lymphoma, Hodgkin's and Burkitt lymphoma, but it does not cause Kaposi sarcoma. A 25-year-old female has developed fever, sore throat and lymphadenopathy accompanied with atypical lymphocytosis and increase in sheep cell agglutinins. Her diagnosis most likely sheep cell agglutinins and atypical lymphocytosis are all characteristic of infectious mononucleosis. Which of the following adenovirus serotypes cause epidemic keratoconjunctivitis? It is caused by serotypes 8, 19 and 37. And all of the following are true about rhinovirus except more than 100 antigenic types have been identified. Yes. Acid labile, yes. Incubation period 10 to 14 days. No, it's not so long. And transmitted by respiratory route, it is also correct. So the incubation period, it's only about 2 to 4 days. Okay. So this completes our chapter. Next we'll be starting with the parasitic infections and the fungal infections of the respiratory tract. Meanwhile, like and subscribe. Thanks for watching.